Good evening, everyone. First of all, let me thank the organizers and the scientific committee for inviting me to present this topic in this conference. I'm going to speak about the segmental approach in congenital heart diseases. Uh, the 2019 guidelines were published by JACE regarding the comprehensive TE examination in children in various congenital heart disease. I think one should go through this. Now, as we all know, the heart consists of three main segments: the atria, the ventricles, and the great arteries. Now, and ventricles are joined by the AV canal, and the ventricles and the great arteries by the conus or the infundibular. The AV canal consists of the right and left-sided AV valves and also the AV septum. Now, why we want to know about the segmental analysis? Because in different cardiac diseases, if you want to know the cardiac anatomy in a systematic manner, we should follow the certain protocol. Usually, there are 9 important steps in this sequential congenital analysis. I'll come to them one by one. The first one is the thoraco-abdominal situs. Thoraco-abdominal situs means what is the normal position of the thoracic and abdominal organs. Most of the organs in the body, they have a particular position. The single organs are asymmetric in distribution and they are distributed either to the right side or to the left side. While the bilateral organs usually have different morphology. Now the situs solitus, the atrioventricular, the atrial situs is associated with the thoraco-abdominal situs. That is why it is important to know about the thoraco-abdominal situs first. So example where the liver is on the right side and the spleen is on the left side. This is situs solitus or the normal condition. In situs inversus totalis, we have the mirror image of the normal, which is exactly opposite. That is the right-sided images you see on the left side and left on the right side. So this is called a situs inversus totalis. For example, in this image, you can see the liver on the left side and the spleen on the right side. And then we have situs ambiguous. When the anatomy is neither situs solitus nor it is situs inversus, then we have the situs ambiguous. Here you get an abnormal symmetry of the organs. For example, all the bronchi, the lungs, and the abdominal organs may have symmetry in their position. Usually, it is associated with the heterotaxy syndrome, which is also have polysplenia or asplenia. This is an example of the CT scan abdomen. You can see the liver in the midline as well as on the right and left side. The stomach is on the right side, and there are multiple spleenules. That is the polysplenia is there in this condition. So the anatomy is ambiguous. On the transesophageal echo, you can see the liver on the right side. This is a very important examination of the thoraco-abdominal situs. Now coming to the cardiac positions. Next is the cardiac positions. Now in cardiac positions, we want to know two things. One, what is the spatial orientation of the cardiac mass and what is the long axis of the heart. Now if you put a sagittal plane, the cardiac mass can be on the right side of the hemithorax or it can be on the left side of the hemithorax. Normally, when the mass is on the left side, it's called levocardia. When it is on the right side, it is called dextrocardia. And when it is in the midline, it is called mesocardia. And the second thing is the long axis of the heart or the base to apex axis of the heart. There can be three positions: the leftward pointing apex or the long axis pointing to the left, apex pointing to the inferior side, or the rightward pointing apex. Now with these two, we have different combinations. In normal person, we get the levocardia, that is the mass is on the left side and the axis is pointing to the left, or the heart apex is pointing to the left. In primary dextrocardia, which is associated with the situs inversus, the mass is on the right side, so there is a dextrocardia and the apex points to the right. In secondary dextrocardia, which occurs because of tension pneumothorax on the left side or because of agenesis or collapse of the right lung, which causes the heart to get pulled to the right side. So you have dextrocardia, but the apex points to the left side. And then we have the fourth condition, mesocardia, means the heart is in the midline and the apex points inferior. There's a good article published in the Annals of Cardiac Anesthesia 2013, where the authors have given images of the dextrocardia. Now this is our patient. You can see the situs inversus mirror image dextrocardia. The LA and LV are on the right side of the image. the RA and RV are on the left side of the image. In the same patient, if you see, usually at 45 degrees, you see the RV inflow outflow view, and in the long axis at 135, you see the LV long axis view. Here, exactly opposite has happened. The RV inflow outflow view is seen at 135 degree and the LV long axis view at 45 degree. Similarly, the extended bicable view is usually get at 130 degree. Here we are getting at around 73 degree. The coronary sinus is opening in the RA, but it is in an inverse position. If you go to transgastric views, the deep transgastric long axis view usually we get around 0 to 5 degree. Here we are getting it at around 143 degree. So there is a inversus condition that images are reversed. So after knowing out the situs and the cardiac positions, we'll come to the visceratrial situs. Now, what is atrial situs? The atrial situs solitus means the RA is on the right side and the ALA on the left side. And in inverses, the ALA is on the right side and the RA is on the left side. When the anatomic landmarks of the RA and ALA are not sufficient to determine the situs, it is called situs ambiguous. This is about the atrial situs. Now, how to identify the right and left atrium? The right atrium is identified by opening of the SVC, the IVC, and the coronary sinus in the chamber. And if you have, again, the CT, that is the crista terminalis, can be seen in the right atrium. If you have 3D echo, you can have NFS view of the right of the atrial septum from the right atrial side. You can see the SVC, the crista terminalis, and the right atrial appendage. If you see here, characteristically, you see the limbus and the fossa ovalis. The limbus is formed by the secundum septum, which is seen on the right side. Now, how to identify the left atrium? Left atrium can be identified by opening of the pulmonary veins. So, left and right pulmonary veins open in the left atrium. There is a warfarin ridge and a left atrial appendage. If you have 3D echo, you can see the valve of the PFO from the left atrial side. So, these are the features of the left atrium. This is how we can identify the left atrium. Now, what is situs ambiguous? Atrial situs ambiguous means it is typically associated with the heterotaxis syndrome. And then we have some 5 variants, that is the common atrium, IVC interruption, bilateral SVC, unroofed coronary sinus, and atrial isomerism. I shall come to them one by one. This is an example of the common atrium where the interatrial septum is not there. So RA and LA, they are practically a single atrium. Then this is the LSVC. We already have seen the right SVC. Now LSVC is usually sandwiched between the left atrial appendage and the left pulmonary vein. You can see here this is the LSVC, the left pulmonary vein, and the atrial appendage here. And if you inject agitated saline in the left hand vein, characteristically you see the micro bubbles coming out to the coronary sinus into the right atrium. So this is how you can identify the bilateral SVC. And then we have something called as a isomerism. Normally, the right atrial appendage is triangular in shape and it has got a broad base, whereas the left atrial appendage is long, narrow, just like a finger. In isomerism, when there is a asplenia, you get both sides, you get the right atrial appendages and you get the apartial pattern of the bronchus. When there is polysplenia, on both sides you get the left atrial appendages, isomerism, and which is associated with what is called as a hypatrial pattern of the bronchus. This is an example of the IVC interruption. The IVC is interrupted usually between the hepatic vein and the renal vein. This is very small IVC, as you know, usually it should be 1.5 centimeters interruption. Now coming to the ventricular loop. So we have seen the atria, now coming to the ventricular loop. We have to identify 2 things here. First, how to identify right and left ventricle, and secondly, how to know about the ventricular loop. Now, as you all know, right ventricle is triangular in shape. This is a 3D echo which shows the right ventricle, which is triangular in shape. Here also you can make out the triangular shape. Characteristically, the septal leaflet is attached to the interventricular septum. And then you see additional bands that like the moderator band or the septal band. You can see the moderator band here also. If you have 3D echo, the right ventricular septum is heavily trabeculated. You can see in the end face view of the right ventricular septum. So this is how you can identify the right ventricle. Now, the left ventricle can be identified by conical shape. Characteristically, the left ventricular superior surface is smooth, whereas towards apex it is trabeculated. There are 2 papillary muscles, but both of them are not attached to the interventricular septum. You also see the aortomitral continuity, and then if you have thickness, you can measure. Usually the LV is thicker in size than the RV. This is how you can identify the RV and the LV. Now coming to the ventricular loop. Now heart develops as a linear tube from different segments, that is the primitive atria, then the ventricles, bulbus cordis, and the truncus arteriosus. Now in a normal condition, this tube bends on itself. If it bends to the right, it is called D loop. If it bends on the left side, it is called L loop. D loop is normal, L loop is usually associated with a pathological condition. So why we are worried about the L loop? Because there may be abnormal coronary arteries patterns, there may be conduction defects, AV blocks, sometimes FC-like malformation or hypoplasia of the left-sided RV. So these are the conditions associated with the L loop. A surgeon can identify by something called as a principle of chirality. So if the surgeon insert his right thumb in the tricuspid valve and his fingers in the RVOT, then the palmar surface of the hand facing the interventricular septum, this is called D loop, which is a normal condition. In L loop, when the surgeon insert his finger in the tricuspid valve and his fingers in the RVOT, this palmar surface facing the ventricular septum, it is called L loop. Now this is for the surgeons to identify. Echocardiography, there is a good article published in recently last year in the Indian Academy of Echocardiography, and what they suggest is the tricuspid valve or the RV inflow valve, if it is on the right side of the mitral valve, it is called D loop. If the tricuspid valve is on the left side of the mitral valve, it is called L loop. It is very simple. In most of the conditions, this corresponds. That means we need not go for all the principal changes. This is what we can identify. Now we'll go to the AV. So we have seen atrium, we have seen the ventricle. Next is the AV segment, which is the first connecting segment. And usually the tricuspid valve will align with the right ventricle and the mitral with the left ventricle, except in two conditions. One is a common AV valve and a double inlet LV. We'll see all the conditions of the atrioventricular alignment one by one. This is called as the AV concordance. That is, the RA will open into RV, LA will open into the drain into LV. This is the normal AV concordance. When there is a AV discordance, the RA will drain into LV and the LA will be draining into RV. So this is the AV discordance. There is a common AV valve associated with the Rastrelli type A complete AVSD. You can see here, and the common AV valve is connected to the crest of the ventricular septum with the chordae. And then we have the tricuspid atresia. You can see the tricuspid valve is atretic here. So both RA and LA are draining through the mitral valve into the LV. The RV is hypoplastic. And then we have the Epstein's anomaly of the tricuspid valve. Classically, you all know there is apical displacement of the septal and the posterior leaflet. There is an atrialization of the right ventricle, and you can see the long sail-like ATL, the characteristic features of the Epstein's anomaly. And then we have the DILV, in which both the RA and LA drain into the LV. So this is the DILV condition. Now, you also heard about straddling. Straddling means basically the crossing over of the chordae to the contralateral ventricle. Now, here I have shown example of the left-sided straddling. The straddling can be grading depending on the mild to very severe. In straddling type A, usually it is attached to the crest of the ventricle, near the crest of the ventricular septum. And straddling type B means almost entire septal surface may be involved. And type C means the free wall of the contralateral ventricle will be having attachment from the body from this side. So straddling also is a part of the AV malformation, alignment, the defects in the alignment. Now coming next to the ventriculoarterial alignments, we have seen the AV. Now we'll see the VA alignments. Now here A is to find out whether the RA and whether the pulmonary artery and the aorta is arising from which ventricle. Now it should be either totally or predominantly arising from one ventricle. If it is just 60% more than 50%, it is called override. And the rule is that all the seminal valves are committed to the great arteries. That means the pulmonary valve will be committed to the pulmonary artery and the aortic valve will be committed to the aorta. How aorta is identified? By coronary arteries and by the aortic branch vessels, aortic arch branch vessels. While the pulmonary artery is identified by confluence and the branch pulmonary vessels. we'll see some of the this thing. There are so many connections of the VA connections. We'll see them one by one. This is normally related great arteries. There is a VA concordance. That means the aorta is committed to LV and the pulmonary artery to the RV. This is a normally related great arteries. This is called a VA concordance. Now, in case of TGA, you see the aorta is anterior and to the right of the pulmonary artery. If you see here, the pulmonary artery is committed to LV and the aorta is committed to RV. So this is example of a DTGA. Next to this thing. Now, if you see the L-pose aorta in a congenitally corrected TGA. So what happens is here, LA will drain into RV, RV will drain into aorta, and RA will drain into LV, and LV will drain into PA. So this is our patient in whom we had done 3D echo. You can see this I explain where the aorta is to the left of the pulmonary artery anterior. So anterior and to the left of the pulmonary artery. This is called L-pose aorta. And now the DORV. DORV, both the aorta and pulmonary artery are committed to RV. So in this patient, you can see the RV is draining into the aorta or opening into aorta, and RV is also opening into pulmonary artery. With a slight change in the sector angle, you can see both the great vessels committed to the RV. This is DORV. In truncus arteriosus, both the branches, aorta as well as pulmonary artery, arise from the truncus. The truncus usually continues as the aorta, and the pulmonary artery arises as the branch of the, here in this is kind of type 1 Collet and Edward classification. You can see the VSD and the truncal valve here. This is a truncus arteriosus. Then there is a pulmonary atresia. From RV to PA, there is no forward flow. There is no antegrade flow. So this is pulmonary atresia. Now, next is what are the types of infundibulum? What is infundibulum first? It's a muscular band which separates the atrioventricular valve from the seminal valve. So all the seminal valve will have one conus, which is called subaortic and subpulmonary conus, which is normally present, which separates from the atrioventricular valve. Now, in the embryonic period, both the conuses are present. What happens during normal development? This is the right ventricle, this is the interventricular septum, and this is the left ventricle. During normal development, the subaortic conus is resorbed. So what happens? The aortic valve is in continuity with the mitral valve. So aortic valve is committed to the LV, and subpulmonary conus persists. So pulmonary artery is committed to RV. This is a normal condition. Now what happens in TGA? Exactly ulta or opposite happens. That is, the subpulmonary conus is resorbed. So the pulmonary valve is in continuity with the mitral valve, while the subaortic conus persists. So the aorta is committed to RV and the pulmonary artery to the LV. In DORV, what happens? Both the conus persist. So both the pulmonary artery and aorta are committed to the RV. While in DILV, both the conuses are resorbed. So both the pulmonary artery and aorta are committed to the LV. So just by the changes in the resorption of the conus, we get so many anomalies. Now, the next is the relationship between the seminal valves, that is the pulmonary valve and the aortic valve, or basically since they are committed to the great vessels, in normally related great vessels or valves, you can see the pulmonary valve is usually superior, anterior, and to the left of the aortic valve. Whereas in inversely related great arteries, it is still superior, but it is on the right side of the aortic valve. What happens in the DTGA, or what is called the deep-pose aorta? The aorta is now anterior and superior, while the pulmonary artery is to the is posterior. There may be anteroposterior relationship also, or the aortic valve can be aorta can be L-post compared to the pulmonary valve. This is an example where you can see the aortic valve is anterior and slightly to the right. This is a short axis view. So in short axis view, if you can see here, the aortic valve is slightly to the anterior to the pulmonary valve. While here, if you see the short axis view, the aortic valve is to the left of the pulmonary valve. So the relation is this aorta is L-post. And now coming to the final anomalies, that is associated anomalies. Now there may be multiple anomalies involving the valves, the septal defects, vena cava, the great arteries, extracardiac anomalies, and the genetic syndromes. So all of these may be associated. So we should look for associated anomalies when you're going through segmental analysis. So coming to conclusion, the sequential segmental approach allows systematic evaluation of all cardiac structures and surrounding organs. The segmental analysis includes examination of 3 primary segments and 2 correcting segments. And all known forms of cardiac anomalies can be diagnosed in patients of all ages, especially when the morphology does not conform to a clearly defined category for identification. So this is how you can do the sequential segmental analysis, and step by step you can identify all the cardiac structures. Thank you very much.